As has been shown in previous large studies of hypomethylating agents plus Venetoclax, a subset of patients with FLT3 mutations, both FLT3 ITD particularly, and less so FLT3 TKD, I do not have as a good outcome as some other subsets of patients treated with this regimen. We had conducted studies in the past combining Azacitidine with Sorafenib for frontline therapy of older, unfit FLT3-mutated patients, and we had shown that the response rate was quite high, about 75%, but the median survival was only about eight and a half months, and so clearly that's not an adequate regimen. And also the combination, as I mentioned, of Azacitidine plus Venetoclax, although produces reasonable response rate, the responses are not durable and relapses commonly occur in the FLT3 mutated population. This comes as an idea for doing a triplet regimen combining Azacitidine, Venetoclax, and FLT3 inhibitor Gilteritinib that is now approved in the relapse setting in the US as a regimen for frontline therapy of older patients with AML who are unfit for chemotherapy. This has been initially a phase 1 study, and of course the combination can be very myelosuppressive, and in the phase 1 study we focused on the relapsed and refractory FLT3 mutated patients. The response rate is high, but the duration of response and toxicity is modest, mainly because we were not completely focused, or we did not know how the doses of the combinations would be in terms of the various regimens, in terms of producing a less toxic and remaining highly effective regimen. Now in the frontline setting, after we have established a very safe and effective combination of regimen with various dose reductions according to our initial phase 1 setting, we have had remarkable high 100% response rate, and these responses have been very durable, and it is very exciting because this could be a future standard for frontline therapy of older unfit FLT3 mutated patients. The question then comes, if in this population we aim to take patients into allogeneic stem cell transplant in first remission, could this regimen be even used in younger and fit patients, essentially put them in remission and then take them to transplant? And I think future studies will hopefully answer this question.